Hello students, this is Dr. Chris Ferrigno. Today we will be discussing the anterior and medial thigh. Before you listen to this lecture, be sure to first view the lecture on the joints of the lower extremity. And next time we will be looking at the posterior thigh as well as the gluteal region before we go down into the lower leg. Be sure to look over these learning objectives for the material on the anterior and medial thigh. Before we dive into the material, let's do a warm-up. So what are we looking at here? Is it a fractured pelvis? Is it a fractured femur? If you said either of these, you'd be wrong. Well, actually what we're looking at is a pediatric patient and their growth plates. The coxal bones are formed by the fusion of the ilium, the ischium, and the pubic bone. At birth, the three bones are connected by cartilage in the area of the acetabulum. Recall that the cartilage does not show up on the radiograph. By around 18 years of age, these bones fuse into a single coxal bone on each side of the body. I first want to introduce you to the osteology of the pelvis that is pertinent to the lower limb. As you already know, the iliac crests are a good landmark for the location of the L4-L5 interspace for performing a lumbar puncture. The iliac crest also serves as attachment points for muscles of back, abdomen, and lower leg. You may recall that in the posterior abdominal wall, we could clearly see the quadratus lumborum coming off of the iliac crest. The iliac crest terminates anteriorly as the anterior superior iliac spine. The inguinal ligament, tensor fasciae lata muscle, and the sartorius muscle that we'll see today all come off close to or at the anterior superior iliac spine, or ASIS. The iliac crest ends posteriorly as the posterior superior iliac spine, or PSIS. A portion of the gluteus maximus attaches here. The AIIS can also be identified, though it is less prominent than the ASIS. The AIIS is a site of attachment for the rectus femoris muscle and for the iliofemoral ligament, both of which we'll see today. The gluteal surface makes up the posterior portion of the ilium. Next time we'll discuss where the gluteal muscles are attaching. But for today, we can see the gluteal surface in this region. The ischium is composed of a body and a ramus. The body of the ischium adjoins with the ilium and the superior pubic ramus above it. The ramus of the ischium is continuous with the inferior pubic ramus. Note that the ramus of the ischium and the inferior pubic ramus combine form the ischiopubic ramus. For the purposes of today, we'll see a few muscles of the medial compartment attaching to the ischiopubic ramus, like the adductor magnus, the obturator externus, and others. The posterior enlargement of the ischioramus is the sit bones, or the butt bone, more accurately termed the ischial tuberosity. A number of muscles in the posterior compartment of the leg will attach to the ischial tuberosity. We also see a number of muscles in the medial compartment attaching to the superior pubic ramus on a notable ridge called the pectineal line. Lastly, the large opening created by the superior pubic ramus, the ischiopubic ramus, and the body of the ischium is the obturator foramen. In life, this foramen is covered by a membrane. I'll just draw that in here. So it's covered by a membrane, and through an opening in the membrane called the obturator canal passes the obturator nerve and the obturator artery. In the previous lecture, we talked a bit about the proximal femur. The head of the femur articulates with the acetabulum and is covered by the articular cartilage, except for the fovea. The fovea, if you remember, is the depression in the head of the femur and is not visible in this picture. The neck is the area between the subcapital line and the intertrochanteric line, which we see on the anterior femur, or the intertrochanteric crest, like we see on the posterior part of the femur. The subcapital line is at the junction between the femoral head and the neck, and the intertrochanteric line runs between the greater and lesser trochanters. Fractures are extremely common in the neck of the femur. Of the bony landmarks of the distal femur and the proximal tibia, those in green represent key points of muscular attachment. Gerdy's tubercle is a bump on the lateral aspect of the tibia where the iliotibial tract inserts. The adductor tubercle is where the adductor magnus attaches, and the tibial tuberosity is where the patellar ligaments attach. During our dissections, we'll come across a very superficial great saphenous vein located in the superficial fascia. The great saphenous vein begins at the dorsal venous arch of the foot and courses up the medial leg through the posterior aspect of the knee and up the medial and anterior thigh and empties into the femoral vein. The small saphenous vein that courses up the posterior leg also originates from the dorsal venous arch and communicates with the femoral vein in the popliteal fossa. Note that this is in the popliteal fossa, which is behind the knee. When the valves in the superficial veins of the leg and thigh become incompetent, and when these veins lose their elasticity, the result is dilated, tortuous veins, which we call varicose veins or varicosities. In the image on the right, we see a natural opening in the fascia lata. This opening, called the saphenous ring, allows for the great saphenous vein to dump into the femoral vein, just inferior to the inguinal ligament. Also living in the superficial fascia near the groin are the superficial inguinal lymph nodes. They're organized into two groups. The horizontal group can be found running inferior to the inguinal ligament, and the vertical group can be found running along the great saphenous vein. Lymph from these two groups will drain into one of two areas, either into the external iliac lymph nodes, seen here, or the deep inguinal lymph nodes, which are found deep to the fascia medial to the femoral vein, seen here. A cross-section of the thigh gives us the opportunity to appreciate that surrounding the muscles of the thigh is deep fascia called the fascia lata. Here we see the fascia lata shown in white, surrounding all the compartments of the thigh. The thigh is divided into an anterior compartment, which is shown in this picture as hunter green, and these muscles are supplied by the femoral artery and innervated by the femoral nerve. The muscles of the medial compartment are supplied by the obturator artery and branches of the femoral artery. Here is a general outline of that medial compartment. The muscles of the posterior compartment are supplied by the perforating branches from the deep femoral artery and innervated by the large sciatic nerve. Here we see an outline of that posterior compartment. The muscles of the anterior compartment will either flex the femur at the hip or extend the tibia at the knee, or in the case of one muscle, it will do both. As we first saw during the dissections of the posterior abdominal wall, the iliacus and psoas muscle originate as separate muscles in the abdomen. The psoas major arises from the transverse processes and the vertebral bodies of the lumbar vertebra. The iliacus muscle is a fan-shaped muscle that consumes much of the iliac fossa, so it has a very large origin point within this iliac fossa. As they cross underneath the inguinal ligament, the muscle fibers merge to insert onto the lesser trochanter. So generally speaking, here's an iliacus muscle, here's a psoas muscle, and distally when they merge, we call this the iliopsoas muscle. The iliopsoas is a powerful flexor of the thigh or of the femur at the hip joint. The psoas major is innervated by ventral rami of L1 through L3, so L1 through L3, and the iliacus muscle is innervated by the femoral nerve, which generally comes off L2 through L4. Within the anterior compartment live the quadriceps muscles, all of which end in the quadriceps tendon that crosses the knee joint and becomes the patellar ligament inferior to the patella. All four of the quadricep muscles are innervated by branches of the femoral nerve. Again, femoral nerve, L2 through L4. The long, straight muscle coursing from the ASIS to the quadriceps tendon is the rectus femoris muscle. Not only will the rectus femoris flex the thigh or flex the femur at the hip joint, but it is also a powerful extender at the knee. The vastus muscles, comprised of the vastus lateralis, medialis, and deep to the rectus femoris, deep to this rectus femoris would be the vastus intermedius, arise from various locations along the femur and extend the knee through the quadriceps tendon. Interestingly, the vastus lateralis and the vastus medialis originate from more of the posterior aspect of the femur than the anterior aspect of the femur. We can somewhat appreciate that in the cross-sectional picture here, where we see that the muscles are almost wrapping around the bone as they emanate from the bone. To see the vastus intermedius wrapping around the shaft of the femur, you'll need to move the rectus femoris to the side. Because the vastus muscles insert into the margins of the patella through the quadriceps femoris tendon, they help to stabilize the position of the patella in the anterior intercondylar fossa during movements of the knee. The sartorius muscle is the most superficial muscle in the anterior compartment of the thigh. It is a long, strap-like muscle that descends obliquely from the anterior superior iliac spine proximally to the medial surface of the proximal shaft of the tibia distally. It shares a common tendon with the other two muscles as it attaches to the tibia. The insertion of the combined tendons is called the pes anserinus, or Latin for goose foot. The name sartorius, or Taylor's muscle, was chosen in reference to the cross-legged position in which tailors once sat. Also, because of the motion that it was required to spin a foot-powered sewing machine, it gave tailors large sartorius muscles. Thinking about this sitting position helps you to learn and understand the sartorius's ultimate action. Considering the distal point needing to move upwards towards the proximal point, you might imagine that the sartorius assists in flexion of the thigh, flexion of the knee, since it does cross the knee and the thigh, and then abduction. It might bring it outward a little bit, since this point needs to go outward towards the proximal point. So there's abduction of the hip, And then there will be some rotation. So that's external rotation or lateral rotation of the hip as well. So flexion, abduction, and external rotation of the hip with some flexion at the knee as well. In the medial compartment of the thigh are a number of large adductor muscles. When you hear of athletes pulling their groin, they have strained one or more of their adductor muscles in the medial thigh. There are a couple of exceptions, but by and large, the adductor group is innervated by the obturator nerve. The gracilis is a long strap-like muscle on the medialmost aspect of the thigh. Here we see it inserting down into the proximal tibia. It descends vertically from the ischiopubic ramus to the pes anserinus on the medial side of the proximal tibia. So now we have seen two muscles going into the pes anserinus. We see the gracilis, and what else? We saw the sartorius. We'll see one more in the posterior compartment of the thigh, the semitendinosus muscle. All three of these go into the pes, so we have one from the medial compartment, we have one from the anterior compartment, and we have one from the posterior compartment. The gracilis, as we've been talking about, will not only adduct the thigh, but because it also crosses the knee joint, it can also act to flex the knee, but it is not very strong in this action. You might imagine that if your femur or if your thigh is very well extended, these muscles in the adductor group may also flex an already extended thigh, or conversely, if the thigh is already flexed, these adductor muscles may help to extend a flexed thigh. Looking further laterally, we can see the pectineus muscle, which is a flat quadrangular muscle. It attaches to the pectineal line superiorly on the superior pubic ramus and courses obliquely to attach to the pectineal line of the femur, shown here in the right picture with the red X, which is a ridge of bone. This pectineal line is a ridge of bone extending from the base of the lesser trochanter to the linea aspera on the posterior surface of the femur, so right about there. Can you remember what we just talked about that attaches to the lesser trochanter? If you said the iliopsoas muscle, you'd be right. The pectineus adducts and flexes the thigh at the hip joint. While most of the adductor muscles are innervated by the obturator nerve, the pectineus muscle tends to be innervated by the femoral nerve, though it can also be innervated by the obturator nerve. Also visible on the left image are the adductor longus and adductor brevis muscles. The adductor longus is a flat, fan-shaped muscle that originates from the body of the pubis. So let's outline this muscle here. As it descends, it flares out to insert onto the linea aspera. So we can see the general insertion point here, but really we can't see where it actually goes into the femur. We have to look at the posterior side. And we can see that here with the black arrow, and now with my annotation we can make out that linea aspera on that posterior femur. The adductor longus adducts the thigh at the hip, and it also can medially rotate the thigh, and it's innervated by the anterior division of the obturator nerve. So adductor longus is innervated by the obturator nerve, the anterior division. Once again, note that if the thigh is exceptionally flexed, the adductor longus can participate in hip extension. Conversely, if the thigh is extended, the adductor longus can help to flex that thigh. The adductor brevis lies just deep to the pectineus and the adductor longus muscles. Here we can make out some portion of the adductor brevis muscle. It is triangular in shape with its apex attaching to the body of the pubis and its base attaching to the pectineal line and linea aspera. So with the pectineus inserting here, and of course the longus inserting into the linea aspera, then the adductor brevis is coming in kind of between the two into this area. Again, it also can adduct the thigh, and it can medially rotate the thigh as well. It also is innervated by the obturator nerve, but both divisions, the anterior and the posterior division. I apologize about my phone ringing. So the obturator, the adductor brevis is the obturator nerve, posterior and anterior. Also notice that I drew in the obturator nerve, seen here. When you're in lab, you'll see the obturator nerve exiting the obturator canal, and you'll be on the lookout for the anterior and posterior divisions of the obturator nerve that course in front of and behind the adductor brevis muscle. So again, you find the adductor brevis and you look for a very shiny obturator nerve anteriorly, and then you have to take a really good hard look posteriorly. It's a little difficult, but you might be able to make out a posterior division of that obturator nerve. As its name implied, the adductor magnus is the largest of the muscles in the medial compartment of the thigh. Like the adductor longus and brevis, the magnus is a triangular fan-shaped muscle anchored at its apex to the ischiopubic ramus of the pelvis and attached by its expanded base to the shaft of the femur and the adductor tubercle of the femur. The magnus is considered to have two parts. The adductor part is the lateral and larger portion of the muscle made up of obliquely oriented fibers that attach to the shaft of the femur. As an adductor, it's innervated by the obturator nerve. So the adductor part is innervated by the obturator nerve, like the other muscles in this compartment, minus the pectineus. The medial part of the adductor magnus, often called the hamstring part, originates from the ischial tuberosity and extends down and inserts onto that adductor tubercle on the medial condyle of the femur. This portion of the muscle works with the hamstring muscles to extend the thigh, although it can also behave as an adductor as well. Just like the hamstrings, it receives innervation from the tibial part of the sciatic nerve. So the hamstring part is innervated by the tibial nerve of the sciatic. The large oval gap between the hamstring and the adductor parts of the muscle is the adductor hiatus, which allows the femoral artery and vein to pass from the adductor canal into the popliteal fossa posterior to the knee. The obturator externus is a flat Also note the perforations in the adductor magnus close to the shaft of the femur. As the deep femoral artery arises from the femoral artery, the deep femoral artery gives off perforating branches, which serve as the primary blood supply for the posterior compartment of the thigh. The obturator externus muscle is a flat, fan-shaped muscle that covers the obturator foramen and the membrane anteriorly. Its muscle fibers converge to form a tendon, which passes posterior to the hip joint and inserts onto the femur at the trochanteric fossa between the neck and greater trochanter. So we see that up here. Because of the orientation of this muscle, the obturator externus externally rotates the thigh at the hip joint. It is innervated by the posterior branch of the obturator nerve. The femoral triangle is a wedge-shaped depression in the upper anterior thigh formed by the thigh muscles inferior to the inguinal ligament and by the inguinal ligament itself, which is the base of the triangle. The medial border is the medial margin of the adductor longus muscle in the medial compartment of the thigh. The lateral margin is the medial margin of the sartorius muscle, which is in the anterior compartment of the thigh. The floor of the triangle is formed by pectineus and iliopsoas. We can make out that pectineus here, but iliopsoas is obscured by the neurovasculature. The apex of the femoral triangle points inferiorly and is continuous with a fascial canal called the adductor canal. It's going to be down in this area. The femoral artery can be palpated in the femoral triangle just inferior to the inguinal ligament and midway between the ASIS and the pubic symphysis. Within the femoral triangle, the femoral artery, femoral vein, and associated lymphatics are surrounded by a funnel-shaped sleeve of fascia called the femoral sheath. Note that the femoral nerve is lateral to femoral sheath in the muscular compartment. A good way to remember all of these structures is with the mnemonic naval, N-A-V, lowercase e, and L. The N, of course, we're going from lateral to medial. The N is the femoral nerve, the A is the artery, the V is the vein, the E is the empty space, and then the L are the lymphatics. The femoral sheath is an extension of fascia, that's transversalis fascia and iliacus fascia, from the abdomen, and it merges inferiorly with connective tissue associated with the vessels. Each of these three structures surrounded by the sheath is contained within a separate fascial compartment within the sheath. In lab, you'll divide the femoral sheath to clearly visualize the vessels. The most medial compartment, the femoral canal, let me draw that in, the femoral canal, contains the lymphatic vessels, fat, and loose connective tissue. It is conical in shape. The proximal opening of the femoral canal is called the femoral ring, which is a weak part of the myopectineal orifice and therefore is the site where femoral hernias can occur. The general site at which inguinal hernias occur is called the myopectineal orifice of Fouchard. This orifice is an ellipse bound by the rectus abdominis muscle, the transversus abdominis muscle, and the superior pubic ramus. There happens to be a lack of muscular reinforcement in this area. As such, a loop of Bow or a lipoma can slide down through the femoral canal and emerge into the femoral triangle from under the inguinal ligament. I like to think of the mechanism here because if you recall, the femoral canal is containing empty space along with those lymphatics and loose connective tissue. Therefore, it's that empty space that allows for structures to go into this area. In this illustration, the herniation is even protruding from the saphenous opening. While femoral hernias tend to be rare in general, they do occur and are more common in females, older patients, and those who have already had an inguinal hernia repair. The adductor canal, or the subsartorial or Hunter's canal, is a fascial tunnel extending from the apex of the femoral triangle to the adductor hiatus. The canal starts in the middle one-third of the thigh and is surrounded by muscles, namely the sartorius, the adductor longus, and the vastus medialis, not shown in this picture. It is through this canal that the femoral artery and vein pass on their way to or from the popliteal fossa, where they change names to the popliteal artery and vein. Also passing through the canal is a cutaneous branch of the femoral nerve called the saphenous nerve, which provides cutaneous innervation to the anterior medial leg. So these structures will then pass through this area and go posteriorly into that popliteal fossa. The main nerves of the anterior and medial thigh, namely the femoral and the obturator, originate from the lumbar plexus. Now, before you have a panic attack, you don't need to be able to draw this out. When we were in the abdomen, we saw the origin of several of these nerves from the lumbar plexus. For the purposes of the lower limb, I want you to know that the femoral nerve comes from L2 through L4 and innervates the muscles of the anterior thigh. The obturator nerve also comes from L2 through L4, which is quite convenient, and innervates the adductor group of the muscles of the medial thigh. For purposes of the lower limb, the genitofemoral nerve is a cutaneous nerve for the upper anterior thigh, and the lateral cutaneous nerve supplies the upper lateral thigh. The femoral nerve, carrying contributions from the ventral rami of L2 through L4, leaves the abdomen by passing under the inguinal ligament to enter the femoral triangle. Remember, it is not contained in the femoral sheath and is positioned lateral to the femoral artery using that mnemonic navel. The femoral nerve innervates all the muscles of the anterior compartment of the thigh. In the abdomen, recall that it gives rise to branches that innervate the iliacus muscle as well, and it often innervates the pectineus muscle. It also innervates the skin over the anterior aspect of the thigh, and here we see that cutaneous branch. The saphenous nerve is a continuation of the femoral nerve. The saphenous nerve is a cutaneous branch of the femoral nerve that courses through the adductor canal, then innervates the anterior and medial aspects of the leg. So it's going to innervate in this direction. On the medial side of the knee, the saphenous nerve gives off the infrapatellar branch. I'll try to draw this in green, and courses in this direction, and is often lesioned during routine surgical procedures of the knee, leaving numbness and paresthesia in the distribution area of the nerve distal to the incision. So if you have an incision here, this area might have numbness and paresthesias. The obturator nerve, like the femoral nerve, originates from L2 through L4. It descends along the posterior abdominal wall, and as you may recall, can be found just medial to the psoas major muscle. It passes through the pelvic cavity, enters the thigh by passing through the obturator canal. The obturator nerve innervates all the muscles in the adductor group, except the hamstring part of the adductor magnus, which is innervated by the tibial division of the sciatic nerve. It innervates the obturator externus muscle and provides innervation to the skin on the medial side of the upper thigh. With these images, we can better appreciate the cutaneous innervations of these nerves from the lumbar plexus. We just saw that obturator nerve, its coursing through the obturator canal to serve the adductor group. And here is that cutaneous innervation of the upper medial thigh. The saphenous nerve, again, accompanies the great saphenous vein to supply the skin of the medial leg, ankle, and the foot in this area. And you can appreciate that infrapatellar branch to serve infrapatellarly. The lateral femoral cutaneous nerve leaves the abdomen just medial or inferior to the ASIS, or anterior superior iliac spine, somewhere in this area, and supplies the skin on the lateral side of the thigh. The femoral branch of the genitofemoral nerve passes into the thigh by crossing under the inguinal ligament to innervate the skin over the upper central part of the anterior thigh. The femoral nerve provides cutaneous innervation to the majority of the anterior thigh, seen here. And here we see the distribution of that obturator nerve on the upper medial aspect of the thigh. The femoral artery is a continuation of the external iliac artery. The femoral artery begins at the inguinal ligament, seen here, and ends at the adductor hiatus, where it becomes the popliteal artery. The femoral artery supplies the anterior compartment of the thigh. It gives off the deep femoral artery, or the profundus femoris, which quickly gives rise to the lateral and medial circumflex femoral arteries. The circumflex femoral arteries give rise to the retinacular arteries, seen here, which supply the neck and the head of the femur. Today in lab, you'll find the medial circumflex femoral artery coursing between the iliopsoas and pectineus muscles. The deep femoral artery also sends off those 3 to 4 perforating branches that supply the posterior thigh. Let's suppose we have atherosclerosis of the external iliac, which would gradually occlude the arterial supply to the lower extremity. If the femoral artery was the only artery supplying the lower extremity, we'd have a big problem. Luckily, there is a collateral pathway built in. This collateral system is referred to as the cruciate anastomosis. There is an artery called the inferior gluteal artery that we'll see in the pelvis later on that makes connections with the deep femoral artery through the circumflex femoral arteries and also communicates with the first perforating artery. So, in the event of an occlusion of the external iliac artery, blood can still reach the lower limb via this inferior gluteal artery and its connections to the branches of the deep femoral artery there. So now, knowing what you know from these previous slides, let's suppose we have a herniation of an L3, L4 disc. So in this image, you can make out that herniation. Here's L5, 4, 3. So this right here is that L3, L4 disc. Here's this posterior, it's most likely a posterolateral herniation, but from this image we can see that it's going posterior. What would be affected? The answer to a question like this may not be very straightforward at first, thus the exercise. So how does one approach a question like this? First, we have to know that we're talking more about central lesion or nerve rootlet or root questions. Next, we have to translate the answer choices to nerve roots. Looking at the dermatome map, we can see that the pubic symphysis, or the answer choice A, the pubic symphysis in this area is L1. If we look at the upper medial thigh, we're looking at L2 or maybe L3. If we look at the upper lateral thigh, we're really looking at L2. And if we look at the medial leg, we're talking about L4. So L1 would be, just as a little extra information, this is probably iliohypogastric. L2, L3, upper medial thigh, what is that? That's more obturator. Upper lateral thigh, that's lateral femoral cutaneous nerve. What is L4? Well, if we look down here, L4 is certainly the saphenous nerve. So next, we have to determine which nerves may be lesion. For option A, since we're talking about L1, is transmitted out of the vertebral column higher up than the site of the lesion, so it can't be affected. Well, how did I know that? So where does the spinal cord end within this bony vertebral column? Let me put in our vertebral levels again. L5, 4, 3, 2, 1. We might as well just put a T12 in there as well. And we know that the spinal cord is ending somewhere around the L1 vertebral body, and we can somewhat make that out right there. So while that's the L1 vertebral level, that is the S5. This area right here would be the S5 spinal cord level. So where's L1 coming off? Well, L1 is coming off way up here somewhere. It's traveling down. It's exiting out right here at the underneath the L1 vertebral body, out the L1, L2 intervertebral foramen. So can that be compressed by this herniated disc? I don't believe so. So we can say no to this one. The upper medial thigh, L2, L3. Well, let's do this again. And the L2, L3 is probably coming off just below that L1. So we'll call this L2. This is L3. And these are coming down, and once again, exiting out right here or exiting out right here. Now, certainly, if this herniated disc is herniating posterior lateral, we can't tell that from here. We can only see that it's herniating posterior. Certainly, the L3 root can be compressed at this spot, but certainly the L2 root coming out here is not getting compressed. So when we try to determine if B is correct or incorrect, let's put a little check. Maybe it is. Similarly, L2, when we look at C, the upper lateral thigh, that's L2, maybe a little L3, depending on where we're talking about on the lateral thigh. We can look here at this area and say, no, it will not be compressed. So I'll put a good no there. And then the medial leg, L4, well, L4, as we can see, is going to travel maybe from this level, and it's going to come down. It's going to have to pass right by this herniated disc. So yes, it could easily be compressed by a herniated disc. So we're going to say emphatically that yes, this nerve, L4, can be compressed. And so those signals traveling up the saphenous nerve that are going to feed into L4 will not get to the spinal cord. So let's talk about another clinical situation, that's fractures of the femur. So the neck of the femur is the weakest part of the femur. So this area here is the weakest part. Fractures of the femur typically occur at either the subcapital line in this area or at the intertrochanteric line in this area, but it could occur anywhere in this femoral neck. The angle of inclination describes the oblique orientation of the femoral head in relation to the acetabulum. So here we see how the angle of inclination is measured. So we take the line down the shaft of the femur and another line down the axis of the neck, and we come up with this angle of inclination. The typical angle of inclination is around 125 degrees. And you might imagine that if this angle becomes more acute or obtuse, the risk for fractures might change in one direction or another. In the case of hip replacements, the patient's original angle of inclination must be recreated with the artificial hip. Otherwise, the patient's gait is likely to change, and it may even cause the patient undue pain. If the angle of inclination is less than 120 degrees, the condition is called coxavara, which can manifest itself as a bow-legged position. So we would have a genu varus deformity resulting from a coxavara deformity. This can be caused by congenital or developmental abnormalities, and it's also caused by metabolic bone diseases such as Paget's disease. If the angle of inclination is beyond 135 degrees, we have what's called a coxavara deformity, and this can manifest itself as a knock-knee position or a genu valgus position. Highly related to coxavara and coxavalga, and thus genu valga and genu vara, is the Q angle. So what is the Q angle? The Q angle is a measurement that we take in the clinic that relates the angulation of the femur to the angulation of the tibia. And so here we see a way that this is measured. We take a point on the ASIS, take the midpoint of the patella, and we draw a line between the two. And then we take that same point on the patella, and we take a point on the peak of the tibial tuberosity, and we draw a line there. Here we go. And so we can measure that angle. And that Q angle in men should be roughly 13 to 15 degrees, and in women should be roughly 17 to 18 degrees. So who has a bigger Q angle? Of course, women should have a slightly larger Q angle. So Q angles that exceed that angulation on either men or women, that's called genu valgum. So again, greater is genu valgum, and then lesser is genu varum. So this would be called a valgus deformity, and this would be called a varus deformity. In a total hip replacement, the femoral head, neck, and acetabulum are replaced with synthetic metals and plastics. In a hip resurfacing procedure, the femoral head is not removed, but instead is trimmed and capped with a smooth metal covering. Damaged bone and cartilage within the acetabulum is also removed and replaced with a metal shell. Let's take a minute to review the hip joint vasculature. Here we see the medial circumflex femoral artery and the lateral circumflex femoral artery wrapping around the neck and upper shaft of the femur. Once again, it gives off these retinacular branches or retinacular arteries, particularly the medial circumflex femoral artery, which is hard to see in this image. So these retinacular arteries extend upwards and serve the entire neck and also extend upwards and into the head of the femur. As you might imagine, most of the vasculature to the head of the femur is served by these retinacular arteries. Meanwhile, at the location of the fovea, there is the artery within the ligamentum teres femoris, or the artery to the head of the femur, that serves a smaller area. That said, disruption of any of these, especially an acute disruption of any of these vessels, can ultimately result in what's called an avascular necrosis, or AVN, where you get necrosis of the head of the femur, and then it needs to be surgically removed and replaced, or at least debrided. You should recall that the circumflex arteries of the humerus came off of the third part of the axillary artery. At the hip, the circumflex arteries, both the lateral circumflex and medial circumflex, come off not the femoral artery or not the external iliac artery, but they come off the deep femoral artery. The foveal artery, or the artery to the head of the femur, seen here, comes off of the obturator artery just as it's coming out of the obturator canal. Let's take a minute to talk about incompetent or varicose veins. When the valves and superficial veins become incompetent, and when these veins lose their elasticity, the result is dilated, tortuous veins, which we call varicose veins. Here we see an individual with varicose veins at various locations. The term vena comitantes is used to describe deep veins that course with deep arteries. So here we see a couple of deep veins, and here we see a large artery. Typically, these veins in the lower limb especially rely on the contraction of surrounding muscles to help move blood back towards the heart, which is why when we're in a relatively dependent position, or our legs are in a relatively dependent position, in other words, they're held in a relatively static position with gravity acting upon them, like sitting in a chair, like sitting in an airplane seat, and there is very little muscular movement, or you're sitting sedentary for quite a long time, or let's say trying to take a nap for several hours while in that airplane seat, you could develop clots in the area because these veins are reliant on muscular contractions. This concludes the discussion on the anterior and medial compartments of the thigh. Please, as always, let me know if you have any questions or concerns regarding this material. Thank you very much.